chest pain is like a box of chocolates. You just never know what you're gonna get.
Hello, my name's Forrest Fessmeyer. You can call me Forrest. Would you like a piece of chocolate? I could eat 1.5 million of these. My daddy always says chest pain patients are like a box of chocolate. You never know what you're going to get. There's infarction, there's pneumonia, there's gastritis, there's embolism, there's dissection, there's costochondritis. My daddy says you can tell a lot about a hospital from their chest pain evaluation protocol. Where they been, where they going. I bet if I think real hard, I can remember who developed the first chest pain protocol. He was that wise old man, Dr. Ray Barr. Now I'm going to turn this program over to my daddy, Dr. Francis Fessmeyer, the developer of the Erlanger chest pain protocol. I think I saw my Jenny.
Oh my gosh.
I got to go.
So, anyways, gives you an overview of when patients present with chest pain, how many different things you could be dealing with. And so, it's not, it's definitely not an easy job that you guys have to do, to try to figure out what exactly is going on with these patients. But the first thing that I think I'll just talk about briefly is acute coronary syndrome. And acute coronary syndrome can be classified typically into about 3 different areas: unstable angina, non-STEMI, which is non-ST elevation MI, and then of course STEMI. And what happens, I'm trying to figure out where I should stand for you guys, but so unstable angina is where that plaque is starting to build up in the arterial wall. It hasn't completely occluded the artery, but there's enough plaque there that it's causing the patient to have chest pain at rest. So that's why they call it unstable angina. And you guys might know this, I'm just giving a brief overview. Non-STEMI is where you start to see the ischemic changes on the ECG. That'd be the ST depression in the T wave. And once we move into ST elevation MI, we have a complete occlusion of that artery. So essentially there's no blood flow that's making its way to that area of the heart. So that's why, we look at ST elevation as such an emergency, because the longer that patient goes with no oxygen to that area of the heart, the muscle dies. So that's why we say it's a medical emergency, time sensitive. A little bit of a background on AMI. We know that 1 million people will suffer from an acute MI this year alone, or every year, and 320,000 of those will have a reoccurrent MI, and so the probability of you seeing them again in your ER is probably pretty high if they've had a heart attack. 2 out of 5 of those patients will die excuse me, within 1 year. So that's pretty significant, and that goes back to the longer that heart muscle is without oxygen, the more tissue damage there is, and the lower their ejection fraction is, heart failure sets in. Interestingly, half of these patients will die before they even reach your ER, so to me that's pretty astounding. What is an MI? Well, we know that obviously there's presenting symptoms such as chest pain. I'll go over some of the presenting symptoms in the next slide. There's a rise and fall in these cardiac biomarkers, and obviously ECG changes, which I'll talk about. Some of the things that you guys should be tuning into when patients show up with chest pain or these other subtle symptoms that might not quite say chest pain, they might not be saying chest pain, but they're feeling, nauseous. They've thrown up a couple times, they're diaphoretic. If someone comes in and has been throwing up and it's diaphoretic, those are patients that you really wanna pay attention to because there's probably some underlying cardiac thing going on. Obviously chest pain, pressure, tightness. Chest pain usually radiates up and to the left, usually doesn't go down. Heartburn or epigastric pain is another classic sign. I see a lot of patients with heartburn or epigastric pain that they're not saying chest pain, but they end up in the ER for a long time, and then eventually an EKG is done, and lo and behold, we have an MI on our hands. Shortness of breath, obviously. Some patients will faint and then come in and they're diaphoretic and they'll say, well, I just fainted at home. Well, typically that could be, could be an MI. And obviously, like I said, pain that goes up and to the left. Anyone know what this sign is called? Obviously, they come in and they'll be like, I just have this pain in my chest. Anybody know what this classic sign is called? The Levine sign? I'm sure you've heard about it before, but let's talk a little bit about serum cardiac biomarkers. So when you guys draw labs on these patients, what we are looking for. We have CKMB. There's different types of CK, but we look for CKMB, which is primarily in heart muscle. Troponins are the classic lab that we're gonna look for or look at. I'm not sure if you guys do a troponin I or a troponin T here. Does anybody know? Troponin I. They're pretty similar. They might be off by just a little bit between troponin T and troponin I. But really what happens with troponins, I think I go over it, so myoglobin and LDH and AST, but primarily hone into the troponin. That's the one that you really want to look at. So with the troponin, it shows up early, so you're going to see a bump in the troponin. Usually depending on whether they present early or late in their infarction. If they present early, you're going to see a rise maybe of it'll go from 0.001 to 0.14, or depending on how long they've been having that. It could be 8. It just depends. I mean, if it's high like that, usually they're presenting late, and their infarction might even be complete. So what happens is you'll see that bump in the troponin, and then usually it levels off, and then it rises again 3 to 6 hours afterwards. So when they come to us in the hospital and we've done PCI, we usually will recheck the troponins, and what we see is it rises again. So we have a significant delta is what they call it. And that just means that it rises again and then goes back down about 12 to 24 hours after their infarction. So usually if they have a significant delta, for sure, but by that time the patient's probably already off for PCI and we know what their arteries look like. But it is used for patients that, are presenting that we're not sure whether we should take them to the cath lab, because we might observe them if we think it's pericarditis or a PE, we do a CT, things like that. Sometimes they don't have a bump in their troponin, and that might be something else. Sepsis. Sepsis usually does make your troponin go up too low. We went over this. Does anybody have any questions so far? I should probably stop. And you guys can interrupt me at any time in this presentation. I don't want to go too fast. So if you guys have questions.
This isn't necessarily a STEMI, but we kind of watch them. If you get somebody that's come in swing bed that's had open heart or something, how long is their troponin going to stay elevated? Because it kind of stays up a little while.
If they've had open heart surgery, I think if they've had open heart surgery, their troponin will be elevated for a while. And that's just because, they've gone in there, and I used to work in cardiac surgery, and that was always tricky for us too, because if somebody had ST elevation on the monitor after surgery, we were always like, okay, have they re-occluded a vessel that we just operated on, or is it just, is it from having surgery? So I guess I would say it usually is about 3 days, I think, is the typical number for that. And if they're home and they come back into you, you know, usually by that time you'd think their troponins were back down again. Or from swing, I mean, because usually they're going to be in the hospital for at least 4 days right after surgery, I would say. Yeah. Anybody else have any questions? You guys okay? Can you see all right? Okay. All right, so the ECG is the absolute cornerstone of treatment for STEMI. It is so, so important. And I can't emphasize enough that if you are in doubt, get an EKG. There are some hospitals that have chest pain protocols that say from the waist up, you know. Women, obviously, and diabetics, they don't have pain, and so, I mean, they not always have pain, I should say. But it doesn't hurt to get the EKG. It's probably one of the cheaper tests that we do in the hospital, so. I am going to just briefly go over EKG changes, and I hope this isn't too elementary. If you guys have more in-depth questions, just speak up and I'll try to answer those. But so obviously ischemia, which we talked about, which would be present for non-STEMI patients, are going to see the depression in the ST segment. Trying to think of what else I want to say about that. And that would be your unstable angina in non-STEMI patients. Injury usually occurs, I mean, this can occur with ST elevation. This is the one that we want to watch for. It's indicative of that complete occlusion of the artery. And I always look at this, if you're not quite sure what you're seeing, EKGs can be tricky if you just kind of look at it broadly, and it's kind of overwhelming because there's so much information there and you're taking it all in, but just go lead by lead. And then if you use that template, you can kind of see the contiguous leads are the ones that are color-coded. So when we say ST elevation greater than 2 millimeters and 2 contiguous leads. So the contiguous leads are the colors that match. So for inferior infarction, you're going to see elevation in 2, 3, and AVF. Okay? And that template it's kind of meant to help you through some of that stuff. But I look at that, and what I see when I look at ST elevation on a lot of EKGs is a fireman's hat. You can kind of see that on there. Now, not all is going to look as pretty as that. Obviously, you're going to see lots of different things. You might see really peaked T waves, and it just depends on where the patient is presenting in their MI. But it can also mimic other things, so that's why, you know, if you note ST elevation on the ECG, get another set of eyes on it, you know, get your physician to take a look at it, and start the ball rolling in the right direction. So as I talked about, you know, some patients are going to present after they've had symptoms for a while, and the EKG will often show these Q waves. Q waves on it's either a deflection. It's always a deflection down. So typically this here would go up, but if it's a Q wave MI, meaning they presented late, it's going to deflect down, and it's either going to be 1/3 the amplitude of this, or it'll be about 1 millimeter wide on your EKG. But those are all things that, you know, this is just for your own knowledge. I mean, what I want you guys to know is that if somebody's coming in with a STEMI and you have the physician support, what they're going to do is they're going to talk to the CCU, the consultant, either wherever you, Mason or Rochester, and they're going to say, yeah, it looks like this might be an old infarction, send them our way anyways. You're still going to probably transfer the patient, but the treatment will depend on how late they're presenting in their MI. So typically we send most all of these patients to PCI, but for some, if they're presenting really late into their MI, like greater than 12 hours, There's some studies out there that show that sending them directly to PCI may do more harm than benefit if they're presenting late. So just a little information for you there, but you're still gonna treat them and get them, you know, to a PCI center. I hope I'm not confusing you, because the point is to get the ball rolling and get the patient to where they need to be, so. Again, just another ECG, as I mentioned, you know, look at the ECG, just start lead by lead, you know, look at what's the rate, what's the rhythm, is there ST elevation in any of the same leads? So with this one, you can see, I see the elevation in 2, 3, and AVF. It's pretty obvious, I think. And that would indicate an inferior MI or a right coronary artery occlusion. You can also see some ST depression here in the B leads. So that's the other thing you'll see is usually you'll see ST depression and then depression in the other leads, indicating that they're also suffering from a lack of blood flow. What's the rhythm? Yep. AFib. So this is just a diagram of the different stages of an evolving MI. So you can see POA is a typical ECG. Doesn't have a great ST segment, but anyways, it's trying to show you. And then B with ischemia from, you're starting to see the ST elevation there, and that you have peaked T waves on B. Obviously, you can see in C there's some definite elevation in the ST segment. And then the ongoing infarction just kind of continues, but you begin to see the Q waves in D and E, how they have that deflection here. Downward deflection in the Q. And then F is months later, usually returns to normal. But with these patients, if they're left untreated, they typically will have, they'll have long-term damage to their ejection fraction and to whatever side of the heart that was affected. So let's go into a little bit about criteria for activation. I gave you guys on the template, I put this in there. Hang on just one second, I gotta